Good afternoon, everyone. I'm going to call this meeting to order of the Assembly Committee on Health and Human Services. Members, before we begin, make sure you mute your microphone when you are not speaking to minimize any background noise. And also, please turn your cameras on. Madam Secretary, please call the roll.
Assemblywoman Benitez Thompson. Assemblywoman Black.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblywoman Krasner.
Here.
Assemblyman Matthews.
Here.
Assemblyman Orentliger.
Here.
Assemblywoman Peters.
Here.
Assemblywoman Summers Armstrong.
Here.
Assemblywoman Thomas.
Here.
Assemblywoman Titus.
Here.
Chair Wynn.
Here. We have a quorum. Madam Secretary, if Assemblywoman Benitez Thompson arrives, can we mark her present when she arrives onto the Zoom? I will try to catch that too if I see her join. I'd like to welcome our audience again for joining us this afternoon for Assembly Health and Human Services. Today we have 3 bills, so we are going to try to be as efficient with our time as possible. Before we begin, again, remember to keep your camera on. We will have the opportunity for the public to provide comment, both in support, opposition, and neutral to all 3 of the bills that are being presented. I will be timing just to make sure everyone has a fair and equal opportunity to present their testimony, again, in support, opposition, or neutral to all 3 of the bills that we are presenting. I may take the bills out of order, but it looks like I'm going to take them right now as I'm looking at it as they appear on the agenda. And with that, I will move to our first bill hearing. So I will open up the hearing on Assembly Bill 189. This bill establishes presumptive Medicaid eligibility for certain pregnant women. For those of you that have been paying attention, we did introduce a committee bill that came out of the Interim Health Committee. And we have decided they were very similar, and so you will see some amendments. I believe that Assemblywoman Gorlow has already submitted, and that might be on Nellis, and I'm sure she will talk about it during her presentation of Assembly Bill 189, but it does incorporate that, so rather than hear the same bill twice, we are just going to probably incorporate much of that language and that work that took place during the Interim Committee into Assembly Bill 189. But with that, I will turn this over to Assemblywoman Gorlow. Please begin when you are ready.
Thank you so much, Chair Wynn. Good afternoon, Madam Chair and members of the Health and Human Service Committee. For the record, I am Michelle Gorlow and I represent Assembly District 35. I am also a member of the Nevada MCH Steering Committee, MCH standing for Maternal Child Health. I'm the immediate past chair of Southern Nevada MCH Coalition and the immediate past co-chair of the state MCH Coalition. I served as a member of the Nevada Governor Association to improve birth outcomes under Governor Sandoval, and I was part of the Nevada delegate to attend the Collaborative Improvement and Innovative Network in order to reduce fetal mortality. I am pleased here today to be presenting AB 189. AB 189 is about improving access to health care for pregnant women. And because we all know healthier moms mean healthier babies and lower costs for everyone. As Chair Wynn mentioned, we will be including an amendment that's going to include it's going to include all of AB 193, which was the committee bill that was introduced from the interim. We have heard in this committee that maternal mortality and morbidity is a significant problem in the United States and in Nevada. The U.S. has one of the highest maternal mortality rates among developed countries, and Nevada is no exception, with 129 pregnancy-associated deaths between 2015 and 2019. Another significant issue is preterm birth. A preterm birth is defined as any birth before 37 completed weeks of gestation. I would like to note that the reason we do 37, even though 40 is considered full term, is because we can be off on a due date for a pregnant mom by about 2 weeks. So that 37-week gestation could actually be a 39-week gestation. A preterm birth is divided into 3 categories. based on gestational age. We have extremely preterm babies, which are those that are born earlier than 28 weeks, very preterm babies, which are born between 28 and 32 weeks, and moderate or late preterm babies, which are born between 32 and 37 weeks. Each year in Nevada, we have around 3,800 preterm births. The highest I remember seeing over the last 15 years was 5,400 births. So we've done a really good job of reducing it. However, our preterm birth rate is still 10.7%, which March of Dimes gives us a D+ on their annual report card. Looking at, the vast majority of preterm births are about 85%, are moderate to late preterm, followed by about 9% being 32 to 37 weeks and 6% being extremely preterm. When we're looking at the preterm birth rate, when we break it down to race and ethnicity, African American women have the highest at 13.7%. Native American women are second at 12.1%. Asian ladies are at 11.0%. And then Hispanic and Caucasian women are right around 9.6 to 9.8 respectively. Preterm birth and low birth weight are associated with significant economic, medical, and social costs as well. Preterm birth is not only the leading cause of neonatal mortality, it is also associated with short and long-term disabilities and morbidities. A 2007 review by the Institute of Medicine estimated the economic burden of preterm birth in the United States to be $26.2 billion, and that was in 2005 dollars. That averaged about $51,600 per preterm birth. There's been some updated calculations. I've seen a variety of them that kind of averages preterm birth to be between $65,000 and $76,000. However, the longer you're in the NICU, the longer that can be. A baby born at about 32 weeks averages about $280,000 a year. And I was reading about triplets being born at 28 weeks. They all spent about 2 months in the NICU at a cost of $4 million. While cost estimates vary, studies consistently show that they are the highest for extremely preterm infants, and increasing gestational age by just weeks can result in significant cost savings. This is intuitive, as the earliest preterm babies generally require most time in the hospital. In Nevada, the average length of stay for extreme preterm babies was anywhere from 54 to 78 days in the recent years. The length of stay for very preterm babies was slightly lower, between 49 and 53 days. In contrast, the average length of stay for moderate or late preterm babies was only about 9 to 10 days. And I do want to kind of compare that for a full-term infant who may only stay 1 or 2 days in the hospital, that cost is roughly $2,500 to $2,900. So a huge difference. And just kind of give you a personal story, my son, who was born in 2006, spent 5 days in the NICU, and it cost $15,000. And he was not a super sick baby. He had some feeding issues, some temperature control issues, but he was not a super sick baby. So what do we do to increase the gestational age of babies born in Nevada? We improve prenatal care for moms. Nevada Medicaid is the single largest payer of births in the state, covering more than half of the births statewide. As such, it is uniquely positioned to improve both maternal and child health outcomes. Assembly Bill 189, as we mentioned, the amendment, will improve access to prenatal care and other health services by expanding Medicaid eligibility for pregnant women in Nevada. So as introduced, AB 189 requires Medicaid to expedite enrollment for pregnant women through a policy of presumptive eligibility, which allows healthcare providers to help women enroll in Medicaid without submitting a full application and receive early prenatal care. Specifically, the bill requires the director of the Department of Health and Human Services to include authorization in the state plan for Medicaid for pregnant women to enroll in Medicaid if she is determined to be presumptive eligible by a qualified provider. A qualified provider is an eligible entity for payment under the state's approved plan and is determined by the state to be capable of making determinations. The period of Medicaid enrollment continues until the last day of the month after the month of enrollment, during which a pregnant woman must submit a full Medicaid application for coverage to continue. And I want to make sure that this is on the record. The idea is that the woman does not wait until the end of that second month. We want that application to be in the process of going through while she's getting care, so there's no lapse in care. We don't want her to wait till the end and then it takes another 30 to 45 days to have her be approved. We want that to be done while she's getting care so that she can then be approved and continue that care. The proposed amendment, this policy was also proposed by the Legislative Committee on Health Care during the 2019 and 2020 interim. In fact, the committee voted unanimously to pursue a bill that not only mirrors this requirement, but also expands Medicaid coverage for pregnant women in 3 additional ways. The committee's bill, AB 193, and because of its goals are very similar, we decided to go ahead and combine that. And that was with the approval of Assemblywoman/Chair Cohen, who, as I mentioned, she's the chair of the committee during the interim. Specifically, this means adding provisions to 189 to require the director of DHS, to the extent authorized by federal law, to expand Medicaid coverage for pregnant women in Nevada by allowing them to enroll in Medicaid if their household income is at or below 200% of the federal poverty level, which is $25,760 for an individual or $53,000 for a family of 4, up to the current threshold, which is now 165%. It's also prohibiting DHHS from requiring a pregnant woman who is otherwise eligible for Medicaid to live in the United States for a certain amount of time before enrolling in Medicaid. Currently, lawful residing pregnant women must wait 5 years before they're eligible for Medicaid, and we're looking to waive that. And then we're requiring DHHS to apply for a waiver from the federal government to allow a pregnant woman and her child to keep Medicaid coverage until 12 months after the child is born, so she can be taken care of during the postpartum period. Currently, Medicaid coverage extends only 60 days postpartum, but the data is showing that 50% of maternal deaths occur after delivery and nearly 12% occur 6 weeks postpartum, meaning maintaining access to care is critical in the year after childbirth. And just so you also know, the federal government is also looking at this being considered included in the Federal American Recovery Act. So we're still looking to see if they're going to require that requirement as well. So Nevada is not alone in considering or implementing any of these policies. According to the Kaiser Family Foundation, 42 states have higher income limits for pregnant women than Nevada, ranging from 171% of the federal poverty level in Kansas to 380% of the federal poverty level in Iowa. 30 states expedite Medicaid enrollment for pregnant women through presumptive eligibility. And 25 states allow lawfully residing pregnant immigrant women who are otherwise eligible to enroll, even if they have not lived in the United States for 5 years. And states are increasingly exploring the possibility of extending Medicaid coverage up to 12 months postpartum. But as I mentioned, there is the American Recovery Act that may be including that also. So why is early prenatal care important? We do have Dr. Slotnick, who is prepared to speak on another bill, but I have told him that if he would like to speak on this, I would love to have him. But really, I want to kind of talk before I have Dr. Slotnick mention that early prenatal care is defined at care during the first trimester, so up to about 12 to 13 weeks of care. The U.S. average is 77.6% as of 2019. Nevada is 75.4%. Currently, we rank 37th in 2019, but as early as 2016, we were 43rd. So we are doing better, but I know we can do even better than that. Late to no prenatal care in the U.S. is 6.4%. Nevada has 9.4%. The Healthy People Objective really would like to see that under 5%. We rank, when we compare ourselves to other states, 48 out of 52. We add in DC and Puerto Rico. So I know we can do much better than that. Some of the reasons that we want women to have early prenatal care is so that we can first get a due date, know when she's going to do. Is she pregnant with a singleton or is she pregnant with multiples? We want to get baseline of her vitals. What's her blood pressure normally? What's her weight level? Because we don't want her to gain too much weight. And blood pressure, if that starts spiking during her pregnancy, it can be an indication for preeclampsia, which is a condition that we really don't know why a woman has it. She just has it during pregnancy, and the only cure per se is to deliver the baby. And she definitely needs to be monitored because she can have a stroke. So those are things we want to check out. We also want to do testing for sexually transmitted diseases. Nevada is one of the highest states for congenital syphilis. So we want to make sure we can test and treat women for STDs. We want to do interventions. for women who may be using alcohol, tobacco products, or drug use, both prescription and non-prescription, and manage any chronic illnesses she may have. If she already has diabetes, we definitely want to monitor that. Some women will develop diabetes during pregnancy, and another condition we're going to want to monitor. So we want to get her in as early as possible. So at this time, I would love to turn it over to Dr. Slotnick if he would like to add something. If not, we have a couple other presenters that would like to talk about their story with prenatal care, and then also Dr. Tracy Bumgarner.
Thank you, Michelle. My name is Nathan Slotnick. I'm a high-risk obstetrician, medical geneticist. I was asked by Assemblywoman Krasner to address a specific genetic issue having to do with pregnancy, but I've been in practice for many, many, many years, and I do want to underline precisely what Assemblywoman Gorlow has just accentuated, which is the singular thing we can do to identify and treat and anticipate preterm labor is early prenatal care. Early prenatal care, absent prenatal care, or compromised prenatal care is a 4-lane highway basically to preterm delivery. And if we're trying to provide the best possible care for the pregnant women of the state of Nevada, early prenatal care is the best approach we can have. Thank you.
Thank you so much, Dr. Slotnick. I appreciate you presenting a little bit on AB 189. I was going to have Dr. Brian Irier, who is a perinatologist from Las Vegas, but unfortunately he had other patients that he had to take care of, and so we want our moms to be healthy, so he's treating moms. I do have Christine Hafney, if she's available. I haven't seen, is she? Christine, I would love if you could tell a little bit about your story.
Absolutely. Thank you for letting me speak to our story today. Our adoptive daughter was born at approximately 33 weeks gestation with a condition called gastroschisis. This is when some, or in her case, all of her intestines were on the outside of her body at time of birth. Her lower half was placed in a protective sterile sheet bag called a silo to keep her safe from infection for the first 48 hours until the first surgery could take place. Unfortunately, her intestines began to die off and continued to do so for the first 2 years of her life. As they died off, she had to return to surgery to have them removed. Skylar now only has half of the intestines she should. Skylar spent the first 13 months of her life in the hospital. She went from the neonatal intensive care unit to the pediatric intensive care unit to try and discharge her. She, however, was considered too unstable to go home and was sent to a long-term nursing facility. Until Skylar was 3.5 years old and discharged to us, she lived between the hospital and the nursing facility. Though some children with this condition can tolerate food fed directly into her stomach with tubes, Skylar has not been fortunate. She is now also dependent on a permanent IV that lives in her chest to meet her caloric needs. Even now with her home, she has her IV nutrition 14 hours a day, 2 pumps to infuse that, emergency medications with us at all times, and continuous feeding tubes 24 hours a day. This condition can happen naturally, but in Skylar's case, it is believed to be caused by biological mom's drug involvement. Members of this committee, this is why AB 189 is so important to pass, in hopes to prevent or minimize this condition and life circumstances like Skylar's. Skylar's life could have been very different if help was available for BioMom. Thank you for your time today.
Thank you so much, Christine. And can you mention to the committee how much her medication is?
She is on Medicaid, so we have been given estimates of anywhere from $650 a day to $2,500 a week. Because of her condition, she's still considered rather unstable, and it changes weekly. So how much just that one medication costs, that number itself changes weekly.
Thank you so much. And next we will have a Dr. Tracy Bumgarner.
Hello, Chair Wynn and committee members. My name is Dr. Kelly Bumgarner, and I am the Director of Health Policy at the Children's Advocacy Alliance. This is Miriam, and she's here today because when I had complications that sent me to the ER early in my second trimester, I was able to visit a high-risk pregnancy center the next day and begin a course of treatment that kept us both alive and healthy. I am so grateful for the treatment I received, but I know that if it wasn't for my privilege, the color of my skin, my health insurance, or even the vehicle I used to get to all those appointments, the outcome may have been vastly different. According to the Georgetown Center for Children and Families, Black and American Indian Alaska Native women die from problems in pregnancy 2 to 3 times more than white women. Only 1 in 3 pregnant women living in Laughlin receive early prenatal care. In Washoe, 1 in 5 receive early care, which experts attribute to a disproportionate lack of care in its rural areas. No one experiencing the fear I felt that day should also have to worry about whether they can afford to see a doctor, find a doctor, or find a doctor that will properly address their concerns and save their baby's life. The Children's Advocacy Alliance is thrilled to stand with Assemblywoman Gorlow and the statewide Strong Start Prenatal to 3 Collaborative in support of presumptive eligibility. The collaborative is alarmed by our state's maternal mortality and morbidity rates. We know that access to care increases utilization during early pregnancy. CDC data indicates significant increases in preconception health conversations with providers, folic acid consumption, and postpartum contraception use when women have access to Medicaid. We have established a multi-year statewide plan to increase Medicaid enrollment and utilization to improve health outcomes for low-income pregnant persons and babies. Our goals include presumptive eligibility, extending postpartum coverage, increasing the percentage of federal poverty level at which pregnancy is Medicaid eligible, and ensuring lawfully residing pregnant persons can access Medicaid. Data shows these actions increase the likelihood pregnant women will seek early care and have positive pregnancy and birth outcomes. Pre- and postnatal care are unique instances in which expanding coverages decreases not only adverse health outcomes, but also costs to Medicaid and taxpayers. In 2007, the Institute of Medicine calculated a preterm birth typically resulted in a $33,000 bill, while a full-term birth cost about $3,000. That's a difference of $30,000 per birth. Thank you for allowing us to speak. Thank you for not being loud and disruptive. And thank you for your consideration of these important efforts to protect moms and babies.
Thank you so much for being here today. I really appreciate you. I just want to mention before we go to questions, there are about 50,000 women that do live in obstetric deserts in Nevada. And so again, presumptive eligibility can really help a lot of those women who have to travel long distances to get to a doctor. So if we can presume them eligible and they can work on their application at the same time, we can get them the care that they need. And Chair, I'm available for questions.
Thank you for your presentation, Assemblywoman Gorlow. I love the normalizing of working women. My children would have been vomiting all over me and probably screaming and pulling my hair. So I found that quite impressive that you were able to get through that entire presentation so eloquently with your child. She is an angel. So I also wanted to, I know that this is a reason that you got into politics. And so I think we can all see your passion in your presentation of this bill. So, and with that, my other sentimental, I'm having a mom moment is it's just exciting during Women's History Month that we are sitting here in a committee made up of lots of women and legislative working moms that are at the table and can have those kind of conversations. I don't think it was too long ago that it was a different makeup of a room talking about women's health and pregnancy from someone who has never had a child. So I think that's very exciting. And with that, I will entertain any questions that you might have. And I'd also encourage people to look at the interim committee work that was done on that. I'm having our policy analyst, Patrick Ashton, send that out to the committee on this bill as well as the bill after this. So you can review some of the interim work that was done in preparation for this bill presentation as well. And with that, do I have any questions? If you guys can just raise your hand if you have anything. I see Assemblywoman Titus, and I will have her up.
Thank you, Madam Chair, and thank you, Assemblywoman Gerlow, for this bill, and thank you for allowing me to be a co-sponsor on this bill. We have been, and I've been asking questions for a long time regarding presumptive eligibility and lowering Medicaid cost. I do appreciate all the testimony regarding the cost of premature delivery, the cost of taking care of these children. I just want committee members to understand that when these babies are born, they're ours, and so we take care of them. And so I've been arguing a long time on why don't we take care of them while they're still intrauterine, and we can make them healthier babies when they come out. And so because eventually they're going to be ours. And so I'd rather they be healthy Nevadans than come out with some issues that we then continue to pay for. I think my question would be that to be good for the record, because I'm going to argue this bill as being fiscal. The return on investment argument can be made here for Nevadans. And what does it cost to have these women have prenatal care? We heard about the cost of taking care of their babies after they're born, if there's a problem premature, and whether they're 26 weeks or second trimester, third trimester, and all those numbers. But what will this cost Medicaid by? Did we get a fiscal note on this? And what was the cost estimated per enrollee? Say, is it $1,000 for the prenatal care, or how does that work?
Thank you, Assemblywoman Titus. To you through Chair Wynn. I did just get a fiscal note today and totaled it up, and it's about $6.8 million. I would have to look and see what it is per woman. But when I was doing the math at about 76,000 average, that's 90 babies. That's it. 90 babies we need to get full term, and we're going to break even. With our preterm birth rate being around 3,800, I think that's totally doable. That's reducing our preterm birth by 2%. And with the Healthy People objective of having us at around 9.4% overall, that's more than 90 births. So our goal really is to get, and I have to do the math off the top of my head, 9.4, we would have, sorry, I'm trying to do math in my head. We have about 3,600 or 36,000 births. 10% would be 3,600. So to get 9, we're looking around maybe 3,500. So if we just got those 90, we're on our way to our goal. If we make our goal, we're definitely going to surpass those 90 babies, and this is definitely cost effective.
Yes, and that's the point I wanted to make on the record, is that indeed it doesn't take us many babies or many women to lower the overall cost. So hate to be about numbers on this one, but really Medicaid cost is huge, and with a fiscal note of that size, I think we need to keep it in perspective, because the first response is going to be no, it's too expensive. But I would say not only emotionally and physically for those who testified about the health of their child, that's priceless, right? We can't even put a cost on that. But in real dollars for the state, I think we need to document that. The second thing is to note that we will only do this as allowed by the federal government. So again, and that needs to be noted, that this we won't be doing this and at risk of losing our Medicaid dollars. We have to make sure that we're in conjunction with the federal government regulations. So again, thank you for allowing me to be a co-sponsor.
Great. And thank you for being a co-sponsor.
Do we have any other questions from the committee? If you can just raise your hand if you have any further questions. Assemblywoman Black, go ahead.
Thank you. A couple questions. I'm a little foggy on the qualified provider will decide or help the patient figure out if they're eligible. I understand the intent, but how does that process look when the mom comes in and she's visiting with her provider? Is her provider going to have to ask her those qualifying questions?
For the record, Assemblywoman Michelle Gorlow, and to you, Assemblywoman Black, through Chair Wynn, Yes, the provider will have to ask qualifying questions to make sure that the woman would qualify for Medicaid. Not anybody can just say, oh, I'm going to be presumed eligible and get the care. If they do not meet the federal guidelines, then they cannot be presumed eligible. So there will be questions for the provider to ask the pregnant mom so that we can make sure that she would normally qualify as her application is being processed. The idea is that the provider will have, and I apologize, the provider needs to have in other states a high acceptance rate on their Medicaid. In other states, it's usually between 90 and 95% that they are accepted on Medicaid. So they're not just, again, accepting anyone or presuming anyone eligible.
And Assemblywoman Black, I believe we have Dwayne Young from Medicaid, and he might be able to answer your question with more specificity. Mr. Young, I see you on there. Do you have anything further to add to that to answer Assemblywoman Black's question?
Good afternoon, Dwayne Young, Deputy Administrator for the division. Also here with us is Lisa Swearigan, who is the Chief of Eligibility and Payments. She can speak a little bit more to the actual process. What I can speak to, and the Assemblywoman has done an absolutely phenomenal job really laying this all out. But really the only difference is that these women would receive outpatient ambulatory services in the period in which they were eligible. They would have 60 days, and Lisa can go into those details, to submit their full Medicaid application. Once being made fully Medicaid eligible, we would go back 90 days and cover all of those other services that are outside of the ambulatory outpatient services related to the pregnancy. And I'll turn it over to Lisa.
Thanks, Dwayne. This is Lisa Swearigan for the record. I'm the Chief of Eligibility and Payments with the Division of Welfare and Supportive Services. So we currently have a presumptive eligibility program through the hospitals. And that's a process that we have in place where they apply, they get certified, they're trained, they have to meet certain criteria. We would do that of the same with this other group. They would have to go through training, be certified. And then we have a quality control group that goes out and monitors to make sure that they're meeting all of the federal requirements. These individuals are eligible for, we say 2 months, it's actually the last day of the month following the month of enrollment. So it could be 30 days. If say somebody applied at the 30th of the month, they would only get to the end of the following month. So it's important, and Assemblywoman Gorlow did state earlier, it's important that these providers work with these individuals to make sure that they submit that Medicaid application so that we can get them enrolled sooner and make sure that there's not a break in service.
Could I have a follow-up? I think they answered it, but I just want to clarify.
Go right ahead.
I guess that may be where I'm misunderstanding this sentence in section 1.1. Through the last day of the month immediately following the month of enrollment without submitting an application for enrollment in Medicaid, which includes additional proof of eligibility. Is that where you're getting the 60 days and the 90 days? Basically, I don't know. I mean, that sentence was just confusing to me, because how can you, without submitting an application, enroll, I guess is where I'm not understanding.
For the record, Lisa Swearigan. So presumptive eligibility is eligible for, we call it 2 months. And so if they were to apply at the first of, say, March, they would be eligible through presumptive eligibility through March and the end of April. Within that time period, they have to submit a full Medicaid application and the verifications to be determined eligible for Medicaid. If they apply at the end of March, it's the last day of the month following enrollment. So that means they actually only get from March 30th through the end of April. So that's what I'm saying. There's a kind of a shortened window there. But we are, stressing that they get those applications submitted as soon as possible so that we can get them full Medicaid.
Thank you.
Mm-hmm.
Do we have any other follow-up questions? Looking out there. I don't see any at this time. Thank you for your presentation. And at this time, we will go to broadcast services to get ready to take callers and support. It looks like we have quite a few people that have registered to provide testimony on Assembly Bill 189. I just remind our callers to please remember to clearly state and spell your name for the record. Please limit your testimony to 2 minutes. Again, I would encourage anyone to provide any additional written testimony within 48 hours of the close of Assembly Bill 89 if you would like it to be considered that way. We will be timing each speaker just to make sure we have a fair opportunity for everyone to speak. And with that, Broadcast Services, if we can open up the testimony in support of Assembly Bill 189, I will note it is 2:07 p.m. and we'll go ahead.
Thank you, Chair. To testify in support on AB 189, please press *9 now to take your place in the queue. Caller with the last 3 digits of 122, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good afternoon, Chair Nguyen, members of the committee. For the record, my name is Katie Ryan, Katieryan, and I'm System Director of Nevada Government Relations for Dignity Health St. Rose Dominican. I just wanted to go on the record today as an us too in support of AB 189. I too had access to great prenatal care, including many visits to the high-risk pregnancy center. And without that access, things could have been very different for my now 3.5-year-old son, Jack. Let's give that access to everyone. Thank you, and I'm available to answer any questions.
Thank you for your testimony. We can go to our next caller in support.
Caller with the last 3 digits of 362, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Chair. For the record, my name is Katie Robbins, Katierobbins. I am here representing Planned Parenthood Votes Nevada and to voice our support for AB 189. Presumptive eligibility serves the important role of providing immediate access to much-needed health care for pregnant women while also putting them on a path to continued coverage. The importance of quality prenatal and postpartum care is well known, and we are supportive of making it easier for pregnant women to access these services. We strongly support AB 189 and urge the committee to as well. Thank you.
Again, thank you for your testimony. We can go to the next caller in support.
Caller with the last 3 digits of 131, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Chair Nguyen, members of the Assembly Health Committee, my name is Connor Cain, CONNORCAIN, and I'm testifying today on behalf of HCA and Sunrise Hospital in support of AB 189. I'd like to first thank all the sponsors of this legislation, but especially Assemblywoman Gorlow for all of her work on this issue. I do know how important it is to her. I'd also be remiss if I didn't thank Director Bierman and Director Whitley for always having an open door to work on and discuss issues related to Medicaid. And last but not least, after what we heard earlier, I do want to recognize Skylar's bravery and toughness. I'm sure she's an inspiration to everyone listening or watching today. As many of you are aware, Sunrise Hospital is the largest provider of Medicaid services in the state. It's something we're extremely proud of, but given that our state ranks 49th in Medicaid expenditures per capita, it's also challenging. Roughly 4,500 babies are born every year at Sunrise Hospital, and about 80% of them are covered by Medicaid. The most vulnerable of these babies end up at the hospital's 72-bed NICU, which is the largest and most comprehensive in the region. It has nearly 1,000 patients annually, and by itself results in significant losses every year due again to low reimbursement rates. One of the most significant problems that the hospital sees every day is the lack of prenatal care that many moms receive. We support AB 189 because we believe it could help lead to better outcomes for moms and babies. We also encourage you to continue to support and prioritize Medicaid funding. We thank you again for your time and for the opportunity to speak today.
Thank you, Mr. Kane. If we can go to our next caller in support.
Caller with the last 3 digits, 199. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good morning, Chair and members of the committee. My name is Tess Opferman. That's OPFERMAN, speaking on behalf of the Nevada Women's Lobby. We want to thank Assemblywoman Gorlow for bringing this legislation forward, which will allow pregnant women access to critical care during pregnancy, through the birth process, and through recovery. Nevada is in the top 12 states when it comes to the percent of women who are uninsured during pregnancy. Please help ensure mothers and babies are healthy by giving access to necessary insurance through pregnancy by passing this key legislation. Thank you for your time.
And thank you for participating in the process. If we can go to the next caller in support.
Caller with the last three digits of 570. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you and good afternoon, Chair and members of the committee. My name is Leah Case, Leacase, here today on behalf of the Nevada Psychiatric Association. The NPA would like to express our support for AB 189 as amended, expanding postpartum Medicaid coverage from 60 days to 12 months following childbirth. According to the CDC Erased Maternal Mortality Update for the Western District, mental health conditions are the leading cause of preventable pregnancy-related deaths. I've submitted this information to the committee secretary. These deaths, including suicides and overdoses, were more likely to occur between 43 days and 1 year after giving birth. Extending postpartum Medicaid coverage for a full year will give mothers continuity of care and access to appropriate treatment for any number of postpartum health issues, including postpartum depression and postpartum psychosis. Babies continue on Medicaid for 1 year after birth. Continuing this coverage for the mother as well will also ensure these babies have a healthy parent too. Thank you.
Thank you. Can we go to our next caller in support?
Caller with the last three digits of 319, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair and committee. Melissa Clement with Nevada Right to Life, MELISSACLEMENT. Nevada Right to Life wholeheartedly supports AB 189, and we thank the sponsor and all those who worked on this very important legislation. Thank you so much.
Thank you for your testimony and support. Do we have any other callers on the line in support?
Thank you, Chair. Caller with the last three digits of 646, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, committee members. My name is Sequila Ankertok, SEQUILA-ANGKRATOK. I am a representative from Human Services Network, calling to voice our support of amended AB 189 on behalf of our many human services member organizations. As a new mother of 2 months, I cannot imagine having to worry about health coverage during my pregnancy. Even with medical coverage, any physical and emotional stress of pregnancy can create a hostile environment for the infant and medical complications for the expectant mother. Lack of adequate and easily accessible medical coverage is an immense stressor no mother should have to endure. I would like to highlight today that pregnant women in Nevada suffering low-income status, often persons of underserved Black and Brown communities, are already a tremendous vulnerable population. According to the CDC, Black mothers are 2 to 3 to as much as 5 times more likely, dependent on age, to die in childbirth than a white woman. And the Black infant mortality rate is well above double that of white infants. These women are already living under tremendous weight of significant disparities within our society, suffering from struggles with nutrition, income, trauma, etc. These women should never have to wonder how they will be able to survive childbirth or bear healthy babies. They deserve the basic human right of access to quality medical coverage both during pregnancy and postpartum. Thank you.
Thank you. Can we go to our next caller in support?
Caller with the last three digits of 817, please press *6 now to unmute. You will have 2 minutes. Please slowly state and spell your name for the record, and you may begin.
Good afternoon, everybody here today. My name is LaShonda Marv Austin, LASHONDA MARVE -Austin AUSTIN. I'm here today to support AB 189 as it's amended. I went through postpartum depression with my daughter. I was not able to properly care or nurse her. Having to put her on formula is something that I didn't want to do. Had I had the opportunity to have extended coverage through Medicaid, I think that I probably would have been able to get support and able to care for my daughter the way I would have liked. So I just want to say thank you for everybody that worked on the bill, and I do want to support AB 189 on behalf of Make It Work Nevada. Thank you.
Thank you. Please go to the next caller in support.
Caller with the last three digits of 035, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon. My name is Quentin Savoy. That's Quentin, Savoy, S like Sam, A like Apple, V like Victor, WOIR. Good afternoon, Chairwoman Nguyen, honorable members of the committee. I'm Quentin Savoy, Deputy Director at Make It Work Nevada. We work alongside Black women and Black families in the areas of economic justice, racial justice, and reproductive justice. We're thrilled that Assemblywoman Gorlow has brought this bill to the committee and that the committee is hearing this measure, as we've long worked to build power to bring greater awareness to issues around maternal mortality in our country. The United States has become the most dangerous place in the developed world for a person to give birth. AB 189 is a racial and reproductive justice issue that is the first step to shake the scourge of this unsettling statistic. By now, I know that you all have heard the research and data about how disparate the realities are for Black women, brown women, and other melanated parents during childbirth. Their access to resources are limited. They're reporting subpar treatment by medical professionals, and in some cases, they're dying. The problem is so pervasive that we can safely assume this is happening in numerous communities throughout our country. The reality is sad in and of itself, but I can't help but think about the children. I can't help but think about how their lives would be more enhanced and enriched if we were proactive in providing mothers and parents with postpartum medical visits, support, and additional care that is currently unavailable to Medicaid enrollees in our state. Current NRS provides for 60 days of postpartum Medicaid coverage. However, this isn't reflective of the needs of the mothers and birth parents that we organize and work alongside. Our community members frequently reference challenges related to fatigue, breastfeeding, and added stress when a new baby comes home. This measure will expand the safety net for our community members that need a little extra support. At its core, AB 189 is about our children and how we intend to raise our children in this state. It meets the moment we find ourselves in trying to bring greater equity to communities that have been historically overlooked or lacked access to care because of restrictive public policy. You all can help us continue making strides in the right direction by supporting AB 189. Make It Work Nevada supports this measure and urges bipartisan support. Thank you.
Go to the next caller in support.
Caller with the last three digits of 585, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good afternoon. My name is Sarah Walton, SarahWalton. I'm voicing support for AB 189. I am a birth and postpartum doula, a childbirth educator, and a midwife assistant. I'm the owner of Bright Heart Birth Services, which is a small birth support and education agency, and a co-owner of Biggest Little Baby, which is a baby store and family resource center, and the current sitting director at nonprofits, the Reno Doula Project and the Truckee Meadows Birth Network. I am and have always been incredibly invested in my community. I am Nevada born. I'm a single parent to a now 6-year-old who was born while I was covered under Medicaid. I was lucky enough to have him up in Portland, where I had far more access to support and resources as a low-income pregnant person. I'm now back in the Reno area. I moved back when I was 6 months postpartum. And I didn't have the same access when I got back here. But I had a lot of intention of creating and building more bridges for community support in the childbearing years in our area because I knew that it was needed. I personally interact with thousands of people in our community through my organizations and leadership, through mentoring, we offer free support groups, and also sliding scale doula support. A large percentage of the people I'm supporting are either supporting Medicaid recipients or Medicaid recipients themselves. We're often supporting these folks before and after they're being seen by medical professionals. So we are sometimes expected to shoulder the burden of things within the medical scope and not the role of doulas. Expanding Medicaid would really be great to include either earlier and later and both. It would improve outcomes for the parents and the babies and their entire families and really get them off to better starts and more secure beginnings as Nevadans. Thank you.
Thank you for your testimony. You can go to our next caller in support.
Caller with the last three digits of 822, please press star 6 now to unmute. There, you're unmuted. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hi, my name is Brianna Lipscomb, BreanaLipscomb. I'm the Senior Manager of the U.S. Maternal Health and Rights Initiative for the Center for Reproductive Rights, and I'm here to express support for the amended AB 189. There are two specific provisions on which I'd like to focus: the presumptive eligibility and the extension of postpartum Medicaid coverage to 12 months. First, with regards to the presumptive eligibility. Presumptive eligibility makes accessing prenatal care simpler and less burdensome. One study found that presumptive eligibility policies increases the likelihood that pregnant women will obtain prenatal care in the first trimester by 30%. Inadequate prenatal care has been linked to preterm labor and low birth weight and many other adverse effects as indicated by Assemblywoman Gorlow. And by removing a barrier to earlier prenatal care, presumptive eligibility encourages access to treatment and services that help improve the health of both moms and babies and may reduce future medical costs. And it's already been said that the majority of states across the country are already implementing presumptive Medicaid eligibility for pregnant women, and this includes many states in our geographic region. Second, regarding extending Medicaid coverage to 12 months after delivery. This is so critical to make sure that birthing people have access to the critical health care services that they need. We know that the majority of maternal deaths are preventable, and data show that 60% of the births in this state are covered by Medicaid, yet women are losing coverage only 60 days after delivery. Ensuring a full 12 months of postpartum coverage is an opportunity to have a major impact on the majority of pregnant and postpartum people in the state. So I urge you all to pass AB 189 out of committee, and it really creates an opportunity for women to achieve their optimal standard of maternal health and is one step closer to closing the maternal health racial disparity gap in Nevada. Thank you.
Thank you for your testimony. If we could go to our next caller in support.
To testify in support on AB 189, please press star 9 now to take your place in the queue. Caller with the last digits of 917, please press star 6 to unmute. Thank you, caller. With the last three digits of 917, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hello and good afternoon, Madam Chair and Committee. Thank you for the opportunity to present my testimony. My name is Ashley Dodson, spelled ASHLEYDODSON. I am a licensed social worker and representative of Make It Work Nevada in support of AB 189 as it is amended. As a Black mother of 5 and previous recipient of Medicaid, I know the disparity firsthand of not having insurance coverage after the birth of a child. My maternal health was at risk for several factors, including the trauma of being considered a high-risk pregnancy. Often after birth, due to my circumstances, it was a struggle to properly care after my children, as the birth was daunting and traumatic. Not only not having access to continued care postpartum also prohibited me from getting my child the proper care they needed in their first weeks after birth, and the necessary well checks, as well as my own health. I also ran into issues of securing quality, affordable child care while working or re-entering the workforce. All of these obstacles caused me to be under increased levels of stress and pressure, which led to postpartum depression and anxiety. I then had to receive therapeutic services, which again, I could not have covered due to lack of insurance and ability to pay cash due to lack of income. This caused me much headache and heartache because I did not have the access to the resources I need for myself nor my children. My experiences did not go as planned, again, because of the lack of insurance and proper care. With Medicaid being expanded into women's fourth trimester, it will decrease other injustices Black women face, such as pay equity, affordable housing, and, as mentioned before, quality, affordable child care. Racism, classism, and sexism have been continuously tied directly to the health and wellness of Black mothers in this country. To conclude, Black women are 3 to 4 times more likely to have pregnancy-related deaths than their white women counterparts. These numbers are staggering and traumatic. Imagine being a woman who throughout your entire pregnancy and birth experience, constantly thinking and knowing the high possibility you may not get to see your child. In the grand scheme of things, no woman should experience this as a result of lack of care and insurance. This narrative has to change. So again, I urge the committee to support and pass AB 189 as amended. Thank you for your time.
Thank you for your testimony. If we can go to our next caller in support.
Chair, the line is open and working, but there are no more callers to testify in support on AB 189 at this time.
I will note that it is 2:28. If we can go to the line, I don't see anyone, but just to double check, are there any callers in opposition to Assembly Bill 189?
To testify in opposition on AB 189, please press star 9 now to take your place in the queue. Once again, to testify in opposition on Assembly Bill 189, please press star 9 now to take your place in the queue. Chair, the line is open and working. There are no callers in queue to testify in opposition on Assembly Bill 189.
Okay, it is 2:29, and I will move to testimony in neutral. I believe we have several people that are on the Zoom that potentially wanted to testify in neutral. Is that correct? Maybe not. Anybody? Okay, then we'll just go to the callers on the line in neutral.
To testify in neutral on AB 189, please press star 9 now to take your place in the queue. To testify in neutral on AB 189, please press star 9 now to take your place in the queue. Chair, at this time, our line is open and working. There are no callers to testify in neutral on Assembly Bill 189 at this time.
You know what? I saw too late Ms. Swearingen. She's on the Zoom, so if we could go to her. If she can unmute and provide her testimony in neutral, we'll be ready for her right now.
Thank you, Chair Wynn. For the record, this is Lisa Swearingen, Chief of Eligibility and Payments with the Division of Welfare and Supportive Services. We wanted to thank Assemblywoman Gorlow and the Legislative Committee for bringing this bill forward. The division would also like to request amending the effective date of the bill to possibly July of 2022, which would allow our agency time to develop and implement those changes. We do have a fiscal note attached to the bill for these system enhancements, but we do look forward to working with Assemblywoman Gorlow and addressing any questions or comments that come up. So thank you.
Thank you, Ms. Swearingen. And with that, I will send us right back to Assemblywoman Gorlow for any closing remarks.
Thank you so much, Chair Wynn. As we've heard with testimony, expanding Medicaid to pregnant women in Nevada is good for moms. It's good for babies. It will help reduce the cost of preterm births, not only in the immediate NICU costs, but long-term costs as well. I want to take a moment and thank Dr. Slotnick for filling in at the last second to give us a little bit more information on prenatal care. Of course, Christine Hafner, she's been a dear friend of mine now for almost 2 years when I first met her, and her wonderful family. So I really appreciate her sharing her story. And of course, Dr. Bumgarner and sharing her story, and her daughter, and everyone that called in today in support. So thank you so very much.
Thank you. And with that, I will close the hearing on Assembly Bill 189. And I will now open the hearing on Assembly Bill 192. This revises provisions governing the testing of pregnant women for certain sexually transmitted infections. Welcome back, Assemblywoman Cohen, to Health and Human Services. Additionally, I will have Patrick Ashton, our policy analyst, also send out a link. This was another bill that came out of an interim committee work that Assemblywoman Cohen was on. And so I'm sure she will go into some of those details, but I will also provide that link. So if you would like to see some of the interim work that was done in consideration of Assembly Bill 192, I would direct our members to look at that. And with that, I will turn this over to Assemblywoman Cohen.
Thank you very much, Chair and Committee, for hearing Assembly Bill 192. For the record, I'm Leslie Cohen, representing Assembly District 29. I'm here today to present 192 for your consideration because it's really important for the health of pregnant women and also for their babies. So a little background information. During the 2019-2020 interim, as you've heard, I chaired the Legislative Committee on Healthcare, and two of our priorities were public health and maternal and child health. This bill addresses both. So before I begin, I'd like to note that there is a submitted conceptual amendment that should be on Nellis, and we'll get into that after we go through the bill. So the problem that we're trying to address is that according to the Centers for Disease Control and Prevention, or as you know, it's CDC, sexually transmitted diseases, or STDs, can cause pregnancy complications and result in serious consequences for both mothers and developing babies. In 2019, the CDC identified newborn deaths from syphilis as, quote, the most alarming threat, end quote, and emphasized the need to test all pregnant women for syphilis in line with CDC recommendations. This is especially important in Nevada because in 2018, we had the highest rate of primary and secondary syphilis in the nation. The problem is especially acute in the Las Vegas, Henderson, Paradise region, which had the highest rates of primary and secondary syphilis of all metropolitan areas that report to the CDC. We also had the second highest rate of congenital syphilis, which is when a mother with syphilis passes the infection on to her baby during pregnancy, and trends have not been moving in the right direction. According to the CDC, Nevada saw a 289% increase in congenital syphilis between 2015 and 2018. Congenital syphilis can significantly affect the baby's health. It can cause miscarriage, stillbirth, prematurity, low birth weight, or even death. Up to 40% of babies born to women with untreated syphilis may be stillborn or die from the infection as a newborn. Congenital syphilis can also result in deformed bones, enlarged liver and spleen, brain and nerve problems, and a host of other health issues. The good news is that both syphilis and congenital syphilis are preventable. Syphilis can be treated and cured with antibiotics, and congenital syphilis can be treated, though babies who have it need to be treated as soon as possible to reduce the risk of serious health conditions. However, key to treatment and prevention are ensuring that moms are tested for syphilis and receive prenatal care. So with that, I'd like to go through the bill with you because this is where AB 192 comes in. The bill aims to align Nevada's STD testing requirements with CDC recommendations. Section 1 of the bill requires physicians and other providers who are permitted by law to attend to pregnant women to ensure they are tested for chlamydia, trachomitis, gonorrhea, hepatitis B, and hepatitis C as recommended by the CDC. The physician or other person must ensure the samples are taken from the woman and submitted to a laboratory. However, subsection 3 provides that pregnant women may opt out of required testing. Section 2 of the bill revises existing requirements related to syphilis testing for pregnant women. It revises who must conduct syphilis testing to ensure it is done and when. The state has found an association between lack of prenatal care and congenital syphilis, and the goal of the bill is to reach pregnant women where they seek health care. So regardless of whether they seek pregnancy-related services. For this reason, Section 2(1)(c) requires hospital emergency departments and certain other medical facilities to test pregnant women for syphilis if they indicate they have not had recommended prenatal screenings and tests. Subsection 2 of Section 2 clarifies when syphilis testing must be done, including at delivery for pregnant women who should be routinely tested for syphilis as recommended by the CDC, live-in areas designated by the Division of Public and Behavioral Health of the Department of Health and Human Services as having high syphilis rates, if they did not receive prenatal care, or if they deliver a stillborn infant after 20 weeks of gestation. Section 3 revises existing criminal penalties for failing to do the required syphilis testing and instead makes them a civil penalty of not more than $500. As for the proposed amendment, when the Legislative Committee on Healthcare held its work session in September of last year, we hadn't quite worked out all of the details for the bill. However, over the past week, I met with the Nevada Hospital Association and the Division of Public and Behavioral Health to iron out a few amendments that should help achieve our goals in a way that the hospital emergency departments can implement. So let me just pull up the amendment and go through that with you. So we replaced a reference to laboratory approved by State Board of Health in sections 1 and 2 of the bill with, quote, a laboratory license pursuant to Chapter 652 of NRS. Next, we deleted section 1 sub 2 such that testing required by this section and done by the state health laboratory is not required to be done without charge. Next, we clarified that hospital and emergency departments and medical facilities must ask women of childbearing age whether they are pregnant, and that was defined by the Centers for Disease Control and Prevention's definition of childbearing age. And if the results of the blood test required in section 2 shows that the pregnant woman is infected with syphilis, and if the result is received while the woman is in the emergency department or medical facility, they must commence treatment for syphilis. Also, when they notify the local health authority of the confirmed case of syphilis, as is required by existing law, they're required to also indicate the case involves a pregnant woman. The next amendment is in section 5, I'm sorry, it's actually amending section 5 of NRS 442.010 to provide that if a pregnant woman objects to the taking of the sample of blood or the serological test for any reason, the sample must not be taken and the test must not be performed. Right now, the existing law allows only an objection for religious basis. Next, this requires health insurance and providers regulated by the state of Nevada to pay for the testing mandated by sections 1 and 2 of this bill. Our next change is revising the list of medical facilities to which the requirements of the bill apply. So we cut down the list in the statute of what is a medical facility. Not actually, let me rephrase that. We didn't change medical facility in NRS, we just cut down which medical facilities need to comply with this. And we've got a list of that on the amendment, so I won't read through those, but you can see that. And finally, we clarified that section 2 sub 1C relates to, quote, an emergency department in a hospital that evaluates or provides treatment to pregnant women, end quote. And this intent is to have hospitals test pregnant women who are evaluated or treated in the emergency department, not just those who are admitted as inpatients, because as you may know, you can sometimes be in a hospital for quite a long time, even days, and technically not be admitted to the hospital, but still be in the emergency room having treatment. So with that, I'd also like to inform the committee that joining us for the hearing are Elizabeth Kessler, who's the STD program manager, and Melissa Peak-Bullock, the state epidemiologist from the Nevada Department of Health and Human Services, Division of Public and Behavioral Health. With that, if either of them would like to make comments, we can take comments, or if they just want to be available for questions, however they'd like to do that.
Thank you, Melissa Peak-Bullock, for the record, state epidemiologist. We are available for any questions. Thank you.
Thank you. So with that, Chair, we're available for questions.
Thank you, Assemblywoman Cohen. We do have a couple of questions in the queue. I have one. I'm going to start here really quickly. Does this just match the CDC guidelines, or are we requesting that all women be tested, you know, in the first and third, it looks like the first and third trimester, or is it just the women that kind of match these risk factors?
Leslie Cohen, Assembly District 29. Well, so we already have first and third trimester in our statutes, but if our stated epidemiologist would like to give a more specific response to the CDC guidelines, please go ahead.
For the record, Elizabeth Kessler, the STD program manager. This aligns with CDC guidance, and we worded this in a way that for endemic areas, we can expand that testing when necessary, with our state being number one in our primary and secondary syphilis rates, and our congenital syphilis rates being second in the nation. We are identified by CDC as one of the hotspots that should not just be looking at risk factor and should be screening all pregnant women.
Thank you for that answer. I also have Assemblywoman Gorlow who has a question.
Thank you, Chairwoman. And I was just curious if it's already being done, or we're just not including it for testing for HPV. That seems to be an STD that a lot of women have, don't even know it. And I know it can cause some problems with babies. So I was just curious if that was something that was already being screened for, or if that was something that this would include.
Our office can check on that, but it was not included in this recommendation.
Thank you.
Do you have any follow-ups, Assemblywoman Gorlow, or was that it? I'm sorry.
That was it. Thank you.
I also have Assemblywoman Titus up next.
Thank you, Madam Chair. So just to be clear, there's already existing language that requires testing on the various trimesters for syphilis, and it has been extremely troubling that Nevada ranks #1 in congenital syphilis, and we during the interim looked at solutions for this, and testing is one. It may not decrease the number of cases of syphilis, but if we can fix the number of cases of congenital syphilis, these babies born with syphilis, I certainly think it's wise to do so. I have some questions regarding the bill specifically, though, and I don't know if they've been amended out or what, but we know that I have a question regarding the terminology in Section 1, Line 1, except as otherwise provided in subsection C, a physician or other persons permitted by law. Currently, are there other persons? Who would they be? Who are those other persons currently in Nevada permitted by law to attend a delivery?
Those other persons would encompass people like APRNs, midwives, other healthcare personnel that may not necessarily be an MD or a physician.
And so can I ask why that terminology of other persons permitted by law, or as opposed to leaving out physicians and just saying a healthcare provider, which is what we've been going to, because over the last several sessions, I've had bills trying to clear language on these healthcares regarding providers. And, you know, when we have PAs and APRNs and we've been kind of going to healthcare provider. I'm just wondering, is this anywhere in our statutes anywhere using that terminology, a physician or other persons permitted by law? It's the first time I'm seeing this.
So just for the record, that was Ms. Kessler answering before. I think we were trying to just clarify, because certainly there are other people who attend upon pregnant women, healthcare providers. And so we wanted to make sure we captured everyone. However, I can work with legal and make sure that we've got the phrasing right to encompass what we're trying to cover. I actually did discuss it with legal when we first got the draft of the bill, and we discussed somewhat, you know, who does that mean, right? It doesn't mean under the definitions, it doesn't mean doula, but who is covered. But we can continue to talk about that and just make sure that it's as concise as possible.
Good, because again, we continually fix these bills after they go through, and one of those is the definition of providers, in which we've worked on several sessions now to include a PA and whether that's a nurse midwife and whether they're licensed to do so or not. But I just think the terminology was different, so I just wanted some clarification with that and would appreciate some follow-up. The next question I have is whether Medicaid, one of the problems when we've heard these bills before, for quite a while, we're always concerned about the cost of doing these tests and who is going to be responsible for paying for these tests. And I'm wondering if Medicaid has said, will they cover these tests if you draw them in the emergency room? Will it be a recognized test that are willing to cover cost?
Right, and I think that was something we, Leslie Cohen, Assembly District 29, that was part of the concerns that the hospital association had, was costs and what they're responsible for. And so my understanding is that it will be covered by Medicaid. So the hospitals will be reimbursed, and obviously they'll be reimbursed by regular insurance. So that was definitely something that we did address in the amendment to make sure that we weren't leaving hospitals financially in the lurch with this.
Great, thank you, because I haven't seen the amendment. May I have one more question, please, Madam Chair?
Go ahead, Assemblywoman Titus.
Thank you. This is in regards to Section 3 and the changing of the wording for consequences if a provider doesn't obtain these tests. There's already been a statute for we as providers are mandatory to do certain testing. And it was already in statute that during this period of time, there would be a consequence. You are taking this out now and adding a physician or other persons attending a woman who fails to perform this. You're adding and including a hospital, medical facility, and these. You're taking it out as a misdemeanor, but you are now putting in fines. So how did you arrive at that? And then I'm concerned about the of subsection 3, number 3, the enforcement through our attorney general or district attorneys, and I'm concerned about the liability for the providers. And I know we want to have a stick. I know we want to make sure that they do this, but I'm very anxious. That's the one pushback I have a couple concerns, but that's a real big pushback for me on those fines to the providers. And so I was wondering where you came with the $500. Is that a standard penalty? Is that written somewhere else if we as a provider don't do our jobs? Is there other penalties? Is this are unique to this bill?
Thank you, Leslie Cohen, Assembly District 29. Well, I think, again, the most important part is that we took out the misdemeanor. Which is an existing law, but there, as you said, there does still need to be, a rod. We need some way to enforce it. 500 is an amount that's used quite often in NRS for civil penalties. We just want to make sure that we do have an enforcement mechanism.
Okay, thank you, Madam Chair, and thank you for the questions.
And I saw Ms. Lynch light up a couple of times. I don't know if she wanted to have a comment or but I wanted to give her an opportunity.
Thank you so much. This is Erin Lynch for the record. I'm the chief of the medical programs unit at the Division of Healthcare Financing and Policy. And I think Assemblywoman Cohen did answer the question about, does Medicaid cover syphilis testing? And in fact, we do. We cover it already in the ER setting, the clinic setting, and even in the inpatient delivery setting. That would be already included in the hospital's daily per diem rate. So overall, Medicaid does cover syphilis testing.
Can I respond to that, Madam Chair?
Go ahead.
So you said that's covered in the Medicaid per diem rate. So the question that I have for that, you paid them a flat rate to see a pregnant woman, and so now if they do the test, there's no additional you know, if you pay them a flat rate, so really you're not really reimbursing them for the syphilis test because you're paying them this flat rate?
Right. For all inpatient services, whether it's very little services done to a lot more services done, no matter what, a hospital gets reimbursed a daily per diem rate.
Right. So in actuality, whether that test is done or not, they're going to get a flat rate. So if they do that test, because they have to pay for that test, it may indeed cost them some money, correct?
We're speaking on the inpatient side. Now for, let's say, the ER
Correct.
side,
Okay.
they would get reimbursed separately for that.
But not in the in-house. Okay, very good. Thanks for that clarity.
Yeah, you're welcome.
Do we have any other questions at this time from committee members? Okay, I don't see anyone going once, going twice. Okay, thank you, Assemblywoman Cohen, for that presentation. I will go now to support in testimony in support, opposition, and neutral of Assembly Bill 192. Again, I would remind all of our callers to please clearly state and spell your name for the record, and please limit your testimony to 2 minutes. We will be timing just to ensure everyone is given a fair opportunity to speak. And with that, Broadcast Services, if we can go to testimony in support of Assembly Bill 192.
To testify in support on Assembly Bill 192, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 199, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, Chair and members of the committee. My name is Tess Opferman. That's OPSERMAN, speaking on behalf of the Nevada Women's Lobby. One of the main goals of the Women's Lobby is to promote the health and well-being of women and families, and it is a top priority of ours to help promote access to affordable health care. We're in full support of this legislation, which will help give access to testing for syphilis, benefiting both mom and baby. Thank you to Assemblywoman Cohen for bringing forward this legislation, and thank you to the committee for your time.
Thank you for your testimony and support. We can go to our next caller.
Caller with the last 3 digits of 200, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chairwoman and members of the committee. Bradley Mayer, BRADLEYMAYER. For the record, I'm a partner at Argentum Partners representing the Southern Nevada Health District. Today, testifying in support. Nevada has been really number 1 or number 2 in syphilis and congenital syphilis in recent years. And since 2014, cases have increased 1,333% for these. The problem is particularly acute amongst women who don't have prenatal care. And so any opportunity we can get to find cases, add to the current efforts that public health is undertaking to mitigate the spread of this disease. And earlier intervention is, of course, necessary to prevent babies being born with syphilis. So we urge your support and we thank you for your time.
Thank you for your testimony and support. We can go to our next caller in support.
For those callers who have just joined, to testify in support on Assembly Bill 192, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 017, please slowly state and spell your name for the record. You have 2 minutes and may begin.
This is Bill Welch with the Nevada Hospital Association, BILLWELCH. First, I would like to thank Assemblywoman Cohen for reaching out to the Nevada Hospital Association to inquire to our perspective on AB 192. I'm speaking today in support of the amendment as being presented by her on AB 192, and we look forward to working with her and others on the passage of AB 192. We think it's a good piece of legislation. Thank you.
Thank you. We can go to our next caller in support.
Caller with the last 3 digits of 672, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, committee, Chair Wynn, and committee. For the record, my name is Joelle Gutman Dodson, JoelleLeeGutman-Dodson, Government Affairs Liaison for the Washoe County Health District. And we're here today in support of AB 192, We'd like to thank the bill sponsor, Assemblywoman Cohen, for bringing this important piece of legislation forward. The Washoe County Health District supports expanding testing for sexually transmitted infections for pregnant women as outlined in this bill. Nevada, like previously stated, Nevada ranks number 2 in the U.S. for congenital syphilis cases, and in the top 15 for states for chlamydia and gonorrhea, indicating the need for more screening to identify infections. We urge your support of this bill, and thank you for your time.
Thank you. If we can go to our next caller in support.
To testify in support on Assembly Bill 192, please press star 9 now to take your place in the queue. Chair, at this time, the line is open and working. However, there are no more callers to testify in support on Assembly Bill 192.
Okay, and if we can go to any testimony in opposition of Assembly Bill 192, I'd like to start that at this time.
To testify in opposition on Assembly Bill 192, please press star 9 now to take your place in the queue. To testify in opposition on Assembly Bill 192, please press star 9 now to take your place in the queue. Chair, at this time, the line is open and working. However, there are no callers to testify in opposition on Assembly Bill 192.
Thank you. And I know that we have several people that registered to testify in neutral, and I believe they are on this call. So I don't know if they want to unmute themselves at this time and present their testimony in neutral. It looks like we have Ms. Lynch. Would you like to go ahead, please? Remember to state your name for the record.
Yes, good afternoon. My name is Erin Lynch. I'm the chief of our medical programs unit at the Division of Healthcare Financing and Policy. And the Division of Healthcare Finance and Policy, otherwise known as Nevada Medicaid, we already cover STD testing for pregnant women, which includes syphilis. So for syphilis, like I said previously, we already cover it in the emergency department setting, in the hospital setting, or in the clinic setting. So we estimate that we would have a $0 fiscal impact on this. And the reason behind it is that we believe that the benefits of testing pregnant women for syphilis and preventing negative health outcomes to mom and baby far outweigh the costs of testing. So we are in neutral support of this bill.
Thank you, Ms. Lynch. Is there anyone else that is on the Zoom here that would also like to present any testimony in neutral? Okay, seeing none, broadcast services, can we go to the phone lines to see if there's anyone that wants to present in neutral?
Of course, Chair. To testify in neutral on Assembly Bill 192, please press star 9 now to take your place in the queue. To testify in neutral on Assembly Bill 192, please press star 9 now to take your place in the queue. Chair, at this time, the line is open and working. There are no callers to testify in neutral on Assembly Bill 192.
Thank you, Broadcast Services. I will turn this back over to Assemblywoman Cohen for any closing remarks.
Thank you, Chair. Leslie Cohen, Assembly District 29. The Legislative Committee on Healthcare chose to pursue this policy change because it has the potential to improve the health of mothers and babies in Nevada, and because congenital syphilis is preventable, and both syphilis and congenital syphilis are treatable. But we need to do better by aligning STD testing with CDC guidelines and expanding testing requirements to hospital emergency departments and other medical facilities. we hope to be able to reach a broader population of pregnant women and reverse these unfortunate trends. I'm certainly open for more questions after the hearing if anyone has any. Also, to Dr. Titus's question about who is a provider in this circumstance. I believe we got that out of 442.008. I will talk to legal though and get a little more of a clarification because that's where it lists who does testing of pregnant women, that type of thing. So with that, thank you. And again, I'm available for questions after the hearing.
Thank you, Assemblywoman Cohen. And again, welcome back to Assembly Health and Human Services. And with that, I will close the hearing on Assembly Bill 192. At this time, I will open for our third and final bill hearing. Thank you guys for being patient. I know these afternoon committees, especially after lunch, can be trying. So if you need to run and get some caffeine, I get it. But I'm sure Assemblywoman Krasner will wake us up with her presentation on Assembly Bill 198. And at this time, I will open the hearing on Assembly Bill 198. This bill requires Medicaid to cover certain genetic testing. And with that, I will begin. I will turn this over to Assemblywoman Krasner to begin when you are ready.
Okay. Thank you, Chair Wynn and members of the committee. For the record, I am Nevada State Assemblywoman Lisa Krasner, and I am here today to present for your consideration Assembly Bill 198, which requires Medicaid to cover certain genetic tests. With me is Dr. Nathan Slotnick. Before I begin, I would like to note that I submitted a conceptual amendment, which is available for you to view on Nellis. Some background information. Prenatal screenings are routine procedures during pregnancy that detect whether a fetus likely has certain health conditions or chromosomal abnormalities. Screening tests are not diagnostic. They only provide a probability that a particular condition exists. Nevada Medicaid is the single largest payer of births in our state. And in recent years, it covered approximately 60% of all births statewide. Currently, Medicaid provides coverage for prenatal screenings, including blood panels, ultrasound exams, amniocentesis, CVS, and chorionic villus sampling. Assembly Bill 198 requires the Director of the Department of Health and Human Services to include in the state plan for Medicaid coverage non-invasive prenatal screening to detect birth defects in the fetus of a pregnant woman who is 40 years of age or older if requested. The intent of this bill is to add non-invasive prenatal screening to the list of screenings that are already available and women can receive on Nevada Medicaid. This is also called cell-free DNA screening and is considered non-invasive because it screens for certain chromosomal abnormalities in a simple blood-drawn sample from a pregnant woman. In contrast with some other invasive methods, such as amniocentesis or chorionic villus sampling, it carries no risk of miscarriage. Non-invasive prenatal screening can be conducted as early as during the first trimester. The conceptual amendment on Nellis clarifies that the requirements of the bill only relate to non-invasive prenatal screening. It also clarifies that nothing in this bill shall be construed to grant, secure, or deny any right relating to abortion or the funding thereof. Madam Chair, I now turn my time over to Dr. Slotnick. He will discuss the scientific and clinical importance of non-invasive prenatal screening and its utility in pregnancy. At the conclusion of his remarks, we are both available to answer any questions you may have. Thank you.
Sorry, I was muted. Good afternoon, and thank you for the opportunity to speak to you today. I have been looking forward to this discussion for some time. Before I formally introduce myself, I want to make sure that I thank Assemblywoman Krasner for her foresight and energy that allowed us to address what I consider a singularly important component of healthcare for pregnant families and pregnant women, one that is frequently overlooked by underwriters and by Medicaid in the state of Nevada. It was Assemblywoman Krasner's contacting me that really got me quite excited for this presentation. I do also want to mention that I fully understand budgetary restrictions and COVID issues having to do with the state coffers. So I won't address the issues of cost during my presentation here today. I'm going to try to share my screen here, and hopefully it's going to work. Maybe not. Can you see this? I'm sharing my screen. Is this visible?
We cannot see your shared screen. Broadcast, could you help the presenter with how to share the screen for us?
I'm sorry.
That's okay.
I thought I had it all set up.
Mr. Slotnick, this is broadcast. If you can look at the bottom of your Zoom screen and see the green share screen button.
Yes.
And if you can just click on that.
Yeah, I thought I. Hang on. I apologize.
No problem.
I'm having trouble even in the Zoom mode now. Okay, share screen.
And then you'll select your presentation that you're showing or click on that.
Hang on, I thought I had this set up. My apologies. It is sending me to a Google Chrome page here.
Do you have your presentation open?
It was.
If you want to open that up first.
It is now open.
And then go back to the bottom of your Zoom and click the share screen.
It's allow Zoom to share your screen. Open system preferences.
Yes. Allow Zoom to share your screen.
All right.
There you go.
All right. Is that visible?
We can see it on our end. Broadcast, can you confirm that the public can see this?
Yes, we can see it. Thank you.
Please proceed.
Very good. I apologize. So let me begin by introducing myself. My name is Nathan Slotnick. I'm a perinatal geneticist. I've been in private practice in the state of Nevada since 2003, providing healthcare, perinatal services, and genetics to the the population of the state, and I've been licensed by the state of Nevada since the year 1990. The goal of our discussion today will be to address a particular area in technology that is relatively recently come to fruition and has tremendous importance in terms of our healthcare. Let me begin by providing you with a little bit of my own background here. I've had long-standing career in academics and research and teaching. I've been involved in somewhere between 70 and 100,000 Nevada pregnancies, providing care, ultrasound, prenatal diagnosis. I also provided medical genetics and genomics services through Renown, and am currently medical director and clinical lead for reproductive health for Inviti Genomics Corporation for the last few months. My career is congruent with the development of screening for aneuploidy or chromosome abnormalities in pregnancy. My first publication was in this area many years ago, and the issues having to do with this particular non-invasive testing protocol is one that I'm intimately familiar with and have done much research on. What we're going to begin to talk about today are a few definitions which I think are crucial. The first thing we'll talk about has to do with what screening really is. And this particular quote that you can see here sums it up quite nicely. It was written by an old friend of mine named Nick Wald many years ago. Screening means the identification among apparently healthy individuals of those who are sufficiently at risk of a specific disorder to justify a subsequent diagnostic test or procedure. This particular definition applies in medicine quite well, but screening is part of human nature. Every time we walk into a room and are faced with meeting new people, we're in a process of a mode of screening when we evaluate them. Identifying a patient, identifying a person, evaluating that person, judging that person is part of what we do as human beings. In medicine, the issues of screening become even more profound and meaningful. In pregnancy, screening is a component of the initial and continuing evaluation in pregnancy. When I ask a patient her age, when she's pregnant, I know that that is a screening tool allowing me to gain more information about what her potential risks for chromosome abnormalities are. We've known for years that as a woman gets older, the risk of a chromosome abnormality in pregnancy goes up. When I ask a woman her ethnic background, I know that that is important as well as a screening tool. We know that certain ethnic groups have certain genetic conditions more frequently found. When I ask a woman her religious background, I know that there are screening for genetic issues implicit in that question as well. I'm Jewish. I know that as a Jew, my risk of having a child with Tay-Sachs disease is much elevated. So all of these are the components of screening, and they are part and parcel of how we provide care to our pregnant women and our pregnant families. So let's return to screening within a medical. Yes.
I'm sorry, we aren't seeing you advancing the slides. If you don't mind just scrolling to the slide that you're presenting on for us.
Okay, can you see that?
No, it's not moving at all.
Oh,
for us.
I'm sorry.
That's okay. We committee, we have access to this PowerPoint, I believe, on Nellis, if you'd like to follow along on that. It is the non-invasive prenatal screening presentation.
I did send that in a few days ago. So we're now on the let's see, it would be the fourth slide.
Great, thank you.
Labeled screening tests versus diagnostic tests. Is that available?
It is, thank you.
Okay, so let's discuss what a diagnostic test is. A diagnostic test is, by definition, a high sensitivity test with a very low rate of false positives and a very low rate of false negatives. A diagnostic test implies a diagnosis will be obtained. And by definition, there is very little overlap between the affected and unaffected population that receive diagnostic tests. We'll see that graphically in just a moment. Next slide. The next slide details what a screening test is defined to be within the context of medical testing and what the applications are. Now, screening tests have a much different application in populations. There's a much broader population application for screening tests. And by definition, the sensitivity and specificity of screening tests are arbitrarily defined. And again, I'll show that to you in just a moment. The arbitrariness of screening tests relates to the definition either by a community or by another defining agency that a false positive and false negative rates can be determined and adjusted empirically. There can be significant overlap between affected and unaffected populations. Next slide. This is that demonstration, this graphical demonstration. On the left, you can see the properties of a test that are used for diagnosis. The unaffected population on the left and the affected population on the right have very little overlap. And so the number of false positives and false negatives are very, very small for a diagnostic test. A screening test, on the other hand, can have a great deal of overlap between unaffected and affected populations. And where you draw the discriminator, the dotted line that you can see on the right side of the screen, will define what your false positive and false negative rates will be. You can move that discriminator and can adjust it arbitrarily and can, if you choose, eliminate your false positive rates or eliminate your false negative. Now, what this did, when these first definitions were applied to pregnancy, it allowed us to identify patients at risk for chromosome issues in pregnancy. The first definition of this was work that we did when we defined, in the next slide, the California alpha-fetoprotein screening program. This was defined by the Department of Public Health in the state of California, the Genetics Disease Branch. At that time, it became obvious that patients who are carrying a pregnancy affected with a spina bifida could be identified by measuring in the mother's serum a protein called alpha-fetoprotein. When those babies were identified, it became clear that their health could be improved by delivering them in a center where they could be addressed immediately and surgically corrected. But what wasn't anticipated was that the alpha-fetoprotein test back in the 1980s also allowed us to define patients or identify patients who are at risk for delivering a baby with Down syndrome. Now, since that time, in the last 30 years, we've gotten much, much better at identifying these patients using different screening tools. The ability to provide this to patients has become routine and customary, and the American College of Obstetrics and Gynecology, the Society for Maternal Fetal Medicine, the National Society for Genetic Counselors has suggested that all patients be provided with the ability to identify what their risks are in pregnancy for a chromosome number abnormality. The ability to do that has even been further expanded by our current development of sequencing, DNA sequencing technologies. This ability has become routine and customary and has allowed us to identify with a high degree of sensitivity and specificity pregnancies that are potentially at risk for chromosome number abnormalities. And how do we do that? Well, we take advantage of the biology of the pregnancy. The interface between the placenta and the maternal uterine wall is dynamic. The placenta, you remember, is fetal in origin. And because of the dynamism of this interface, some cells that are placental in origin will grow, divide, and some will die. If that placental cell dies and releases its contents, some of the fetal DNA indicated in white here can be crossed into maternal circulation, and we can identify, separate, and sequence the DNA of the fetus from a maternal blood sample. Remember, the maternal blood sample is not a at-risk procedure and doesn't put the pregnancy at risk at all. In this particular setting, we know fetal DNA has a much shorter length than maternal DNA in circulation, and our ability to sequence that DNA has become available routinely and is offered to all pregnant women for this particular reason. Using this cell-free DNA non-invasive prenatal screening tool, we're able to provide families and pregnant women with certain options. The first takeaway from this is that cell-free DNA-based non-invasive prenatal screening is increasingly utilized across all pregnancy risk groups. And for the last 10 years, it has offered improved detection of fetal chromosomal abnormalities. Secondly, cell-free based non-invasive prenatal screening is extensively studied and has been extensively studied in the general population with tens of thousands of patients studied and has shown to have a very high positive predictive value compared to other status quo traditional screening tools. Number three, there is a better detection of the chromosome number abnormalities that we can identify than in standard of care other screening tools. This therefore leads to fewer invasive follow-up procedures, fewer amniocenteses, fewer chorionic villus sampling, and by definition, fewer pregnancy-related losses. It is a safer test for both the mother and for the fetus. All major professional societies endorse or recognize this particular tool as a clinically valid screening option for all pregnancies. And as we know, there is a clear disparity in coverage and care for women based on factors as age, location, insurance coverage. We're striving for a single standard of care. It can provide better detection, in the next slide, fewer false positives, fewer invasive procedures, and fewer procedure-related miscarriages. In this particular next slide, we can see that the test is a remarkably powerful one. Not only is there a high positive predictive value, which is on the right side of this right side of this slide, but as you notice in the right bottom corner, there were essentially zero false negative results. Of 15,794 patients tested in this particular study, none of them were falsely identified as negative. It is therefore a perfect screening tool. There are obvious health economic benefits, fewer invasive procedures, improved perinatal outcomes, and reductions for specialist referrals. Now, my particular experience with cell-free DNA and in testing in Nevada is, first of all, it's very well accepted by patients, by providers, and by other clinicians. Number two, it's very easily utilized both in private offices and clinics. One needn't drive all the way to a center to have the testing done. It can be provided in an office in Ely just as easily as it can be provided in Las Vegas. There is a very high comprehension of the test strengths and weaknesses that clinicians, patients, and underwriters have. And we recognize that there is unequal access for this particular test in Nevada geographically, demographically, and financially. Because it is such a great screening tool, as I said, because if it comes back negative, the chance that it's wrong is very, very, very low. It is a perfect screening tool. We also know that there are risks associated with diagnostic testing, and the self-retesting has a very, very low risk and leads to far fewer diagnostic procedures. It is by definition a safer choice. And the goal here is to provide better access and more equity in access to our patients and pregnant women in the state of Nevada. Thank you very much. I apologize for the difficulties with the slides.
No, it happens, Dr. Slotnick. We appreciate you taking the time to present. I think we've all been in this situation. I think every single person on this call with some sort of technical difficulties. So I appreciate that. And thank you, Vice Chair, for standing in for me when I had to step out for a moment. Assemblywoman Krasner, do you have any additional parts of your presentation?
No, I don't. Thank you. We're available for questions.
So I am looking out here. If you guys could just wave if you have any potential questions, and I will be able to call on you at this time. Oh, I see Assemblyman Orlicker, so go ahead.
Thank you, Madam Chair, and thank you, Assemblywoman Krasner, for bringing this bill forward. I think it's very important for all the reasons that you and Dr. Slotnick have talked about. One question I have is, I see that this the access would start at age 40, and my sense is that obstetricians often or typically offer this earlier than age 40. So how did you pick the age 40 threshold?
Chair Nguyen, through you to Assemblyman Orlicker. I know that the age that is appropriate, according to Dr. Slotnick, is age 35 and older, because Nevada is in a budget deficit, hoping to keep the fiscal note as low as possible. I asked for the age to be 40 and over, fully knowing and promising Dr. Slotnick that I would come back 2 years from now and change it back down to 35.
Thank you.
Thank you. Do I have any other questions from committee members? I see Assemblywoman Summers Armstrong. Why don't I go there next?
Thank you so much, Chair Nguyen, Assemblywoman Krasner, for bringing this wonderful bill, and Dr. Slotnick for a really interesting presentation. Has anyone done any research to see if we stick with the age of 40, how many births we would miss if we hadn't just left it at 35? I mean, do we have any data to sort of show us what the difference is? I think Assemblyman Dr. Orlicker, his question is valid. I had a late in life pregnancy, my third time, and I had to go through all of this, but I had an invasive test. And I know that there's, when we're talking all day about discrepancies in delivery in communities of color, when we're talking about the number of births that are being paid for by Medicare, how many are we going to miss by leaving this at 40 instead of bringing it down to 35?
I'd like to answer the first part, and then I'll ask Dr. Slotnick to answer the second part.
Sure.
It's not going to stay at 40. It's going to only be at 40 for 2 years until next session, and then it's going to go back down to 45. I asked Mr. Jenkins if he would give me the statistics and costs that Medicaid would have to reimburse for age 40 and age 35. For age 40, it was about $48,000 per year, and for age 35, it was $300,000.
Assemblywoman Krasner, are you possibly covering up your microphone with paper or something? It sounds like you're slightly muffled.
I'm sorry. Can you hear me?
Perfect. There we go. Now we can hear you.
I asked Mr. Dwayne Young from Medicaid to give me the statistics on age 40 and age 35, knowing we're in a budget deficit. And for age 40, for 2 years, it's a little under 100,000. For age 35, for 2 years, it's 600,000. So in hoping to get this passed this session, I asked it at age 40 just for 2 years. And I do intend to come back 2 years from now to expect to move the age down to 35.
May I comment?
Oh,
can you hear me?
Go ahead, Dr. Slotnick.
Okay, very good. The distinction here is one between what's considered to be high risk and non-high risk. High risk patients for chromosome number abnormality has been a cutoff that has been established for many years and is age 35. The high-risk definition is one that is accepted through a number of different societies, including American College of OBGYN and Society of Maternal Fetal Medicine. The ability to provide service for this particular non-invasive test, though, lags in Nevada for the reasons that I addressed already. The access of a woman in Elko is different than the access of a woman who lives in Reno, Las Vegas. What we're trying to do is initiate the conversation, the appreciation, and the definition, and understand the science and clinical medicine behind it so that this can be an ongoing and dynamic approach to improving the healthcare for families and pregnant women in the state. That won't stop here. It will continue, and we'll continue to discuss it as time goes on.
Assemblywoman Summers Armstrong, does that answer your question?
Thank you, Chair Wynn. It does. I understand Assemblywoman Krasner's thought process, and I'm grateful that this is going to be a continuing conversation. But I also want us to consider when we're talking about maternal health and what we are delivering to our communities, that sometimes we get caught up on the raw numbers and don't necessarily consider what it means if we don't institute things. Are we crunching the numbers to see how much it costs if we have if we don't address some of these issues in vitro through prenatal and then end up with problems after birth, and just something to consider as we're crunching the numbers. But I really appreciate this, Assemblywoman Krasner, and thank you very much.
And then do we have any other comments or questions from the committee members? Okay, seeing none, we will go to Broadcast Services to begin testimony in support, opposition, and neutral of Assembly Bill 198. Again, I will remind callers to please clearly state and spell your name and limit your testimony to 2 minutes. Again, staff will be timing each speaker to ensure everyone is given a fair opportunity to speak. And with that, we will begin testimony in support of Assembly Bill 198. Staff from Broadcast Services, can we please add the first caller?
To testify in support on Assembly Bill 198, please press *9 now to take your place in the queue. Caller with the last 3 digits of 131, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Chair Wynn, members of the Assembly Health Committee, my name is Connor Cain, CONNORCAIN, and I'm testifying today on behalf of HCA and Sunrise Hospital in support of AB 198. I'd like to first thank Assemblywoman Krasner for her leadership and hard work on this incredibly important issue. And rather than repeat my prior testimony in support of AB 189, I'll just say that covering genetic testing for birth defects is something that could lead to improved outcomes for many of the thousands of babies born every year at Sunrise Hospital who are covered by Medicaid. And I'd also like to add that on a personal level, that after a positive diagnostic test a little more than a year ago, my wife was able to get additional care from a high-risk pregnancy center. And today I can report that we have a happy and healthy 8-month-old baby girl. Thank you again for your time and another opportunity to speak today.
Thank you, Mr. Kane, for your testimony. If we can go to our next caller in support.
Caller with the last 3 digits of 319, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Madam Chair and the committee, my name is Melissa Clement, MELISSACLEMENT with Nevada Right to Life. We support the amendment to AB 198. We thank the sponsor for adding it. And of course, while we support testing so that a parent can prepare for a potentially adverse diagnosis, we are concerned that such a diagnosis could be used to screen out babies that are potentially less than perfect. But that is certainly not the point of the bill, and we thank the sponsor again for her help.
Thank you for your testimony and support. If we could go to our next caller in support.
Caller with the last 3 digits of 104, please press *6 now to unmute. Caller with the last 3 digits of 104, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon. My name is Hannah Baer, Hannah, B as in boy, AER, and I'm representing the Coalition for Access to Prenatal Screening to present on the coverage landscape of prenatal screening. CAPS is a collaborative alliance of 7 leading genetic testing companies in the United States that seeks to improve access to non-invasive prenatal screening for all pregnant women. The coalition thanks the Assembly on Health and Human Services for the opportunity to speak in support of Assembly Bill 198, and the coalition thanks the bill's sponsors and co-sponsors for bringing attention to this important issue of access to prenatal screening. Women enrolled in Nevada Medicaid currently do have access to maternal serum screening, including amniocentesis, which provides them information if there is an increased risk of giving birth to a child with a genetic disorder. Non-invasive prenatal screening provides the same information through a non-invasive simple maternal blood draw and is a safer and more accurate screening. A woman with an affected pregnancy may need to deliver her baby in a hospital equipped with resources to manage a high-risk and special needs birth. The information NIPS provides helps to improve maternal health outcomes. State Medicaid programs and commercial payers recognize non-invasive prenatal screening as a sensitive and specific prenatal screening tool that should be offered to all pregnant women. Many of Nevada's surrounding states, including Oregon, Idaho, and California, effective in 2022, cover this screening for all pregnant women. These are 3 of the 18 state Medicaid programs that cover NIPS for average-risk pregnant women. 5 of these 18 states changed following the release of Practice Bulletin 226 by the American College of Obstetricians and Gynecologists in August of 2020, which recommends the screening regardless of age or risk. Furthermore, 25 state Medicaid programs cover the screening for women considered high risk. In contrast, currently Nevada Medicaid remains one of only 7 states in Washington, D.C. that denies this coverage to all pregnant women, even those considered high risk. On the commercial payer side, more than 65 plans nationally covering more than 200 million lives cover NIPS for average-risk women. This includes almost all Blue Cross Blue Shield plans, Aetna, United Healthcare, Cigna, and Anthem. The majority of commercially covered lives enjoy access to non-invasive prenatal screening, and this creates a disparity of care for lower-income women who live in a state in which Medicaid denies coverage. In Nevada, there is a disparity of care even within the Medicaid program, as all 3 of its managed care organizations provide coverage of non-invasive prenatal screening. NIPS provides better detection of common genetic disorders with a lower false positive rate, resulting in fewer follow-up procedures and procedure-related losses. Since Nevada Medicaid's fee-for-service program does not currently cover the screening for any pregnant woman, it creates an environment that is less safe for the mother and child. In addition, there's a clear disparity in access to prenatal care for women in Nevada Medicaid's program compared to their counterparts enrolled in commercial plans. CAPS members support AB 198 as this legislation seeks to reduce the gap in coverage and increase access to prenatal screening for Nevada Medicaid enrollees. This concludes my summary of the coverage landscape and trends for non-invasive prenatal screening. Thank you so much for your time and consideration.
Thank you. Broadcast Services, can we go to our next caller in support?
To testify in support on Assembly Bill 198, please press star 9 now to take your place in the queue. To testify in support on Assembly Bill 198, please press star 9 now to take your place in the queue. Chair, at this time, the line is open and working. However, there are no more callers to testify in support on AB 198.
Thank you. Do we have any callers in opposition to Assembly Bill 198?
To testify in opposition on Assembly Bill 198, please press star 9 now to take your place in the queue. To testify in opposition on Assembly Bill 198, please press star 9 now to take your place in the queue. Chair, at this time, the line is open and working, but there are no callers in the queue to testify in opposition on Assembly Bill 198.
And do we have any callers in neutral?
To testify in neutral on Assembly Bill 198, please press star 9 now to take your place in the queue.
This is Erin Lynch with the Division of Healthcare Financing and Policy, and I was asked to provide a neutral testimony.
Go ahead, Ms. Lynch.
Thank you so much. So everyone should have, it's in the exhibits, the prenatal testing slide. And I'm going to share my screen and just give you a quick little biology 101. So hopefully everyone can see this little slide on normal human karyotype. And basically, I just wanted to quickly show this one piece before I move on to my slide. And I'm very thankful that Dr. Slotnick is also here because he's a clinician and I am not, just in case there's any questions. But for humans, we basically have 46 chromosomes. And when they are paired up, we have 23 pairs. Now things go awry when, let's say, a pair of chromosomes only has one chromosome, or let's say it has 3 chromosomes. So like Down syndrome is trisomy 21, and that means that instead of having 2 chromosomes, there's actually 3 chromosomes. So just a real quick biology 101. And now I'm going to share my slide. Okay, great. So I wanted to provide to the committee what Nevada Medicaid covers for prenatal testing. And so, of course, these are all optional. We don't force any women to have to get tested. Prenatal screening and diagnostic testing is basically optional. And so for screening, and Dr. Slotnick gave some really great definitions here too, but screening identifies the potential chance that a fetus has an abnormal number of chromosomes. So when a test comes, or when a screen comes back positive, means that they have a higher chance of there being an abnormality there. When it comes back negative, there's a lower chance there. So within screening, we have the first trimester screen, second trimester screen, and then the NIPS screen, which is also called cell-free DNA screening. And so the first trimester screen, it is a blood panel with the ultrasound, and it screens for trisomy 18.
I'm sorry to interrupt you, Ms. Lynch. I think there might have been some confusion. We are doing testimony in neutral right now. I think that this probably was more appropriate during the presentation, like in case in chief. I know that we received your documentation, or at least I did. I don't know if other members have received some of the slides that you are referencing right now, but I would encourage you, if it hasn't been provided, and Assemblywoman Krasner, if you could make sure you get those slides to the our policy analysts so they can be distributed to the rest of the committee. I think that would be probably more appropriate. I'm sorry, Ms. Lynch.
That's okay. I was skipped in the presentation slide, and this was provided as an exhibit, and it is posted online as a exhibit. So I was asked by my deputy administrator to just go ahead and present it during the neutral section.
How many slides do you have to present? I'm trying to pull it up right now.
It's just this one slide.
Okay, I'll let you go ahead and finish it up. Obviously, there was some confusion in the presentation of the bill, so go ahead and continue.
I apologize about that. I even put it in the chat that, hey, don't forget me. So second trimester screen also screens for the same chromosomal abnormalities, but it also screens for neurotube defects. So both first trimester and second trimester screens are covered by Nevada Medicaid. And obviously the NIPS test is not covered. And it does screen for one more trisomy, which is trisomy 13. And then on the diagnostic side, whenever a person shows positive for one of these prenatal screenings, the physician is probably going to recommend a diagnostic test, which would then really determine whether that fetus does in fact have that abnormality. So Nevada Medicaid does cover karyotype testing, and the samples are collected via amniocentesis or CVS testing, and it does have a slight chance of miscarriage there too. Or we also cover the FISH test, same type of process. We are in the process, and it's coming very soon, to cover the chromosome microarray analysis, also known as the CMA test. But we do not cover like individual DNA tests. Like, let's say if you wanted to test the baby for cystic fibrosis, we don't cover those individual tests. We do allow for items that we don't cover to be overridden with the EPSDT admin exception when it's medically necessary for pregnant women who are under the age of 21. And then also at birth, Nevada Medicaid does cover newborn screening, which screens for 31 chromosomal DNA metabolic disorders here in Nevada. Some of the advantages, NIPS, like I said, NIPS does screen for trisomy 13, so it's an additional test there. And ACOG, the American College of Obstetricians and Gynecologists, does recommend that all women be offered prenatal screening regardless of age. So we are currently only offering 2 types, but this bill would offer a third type. And you should also have our fiscal impact on this particular bill as well. Any questions?
May I comment?
I'm sorry, who was that?
That's me, Slotnick.
Go ahead, Mr. Slognan. If you could keep it brief, I know we have other members that have to go to committee at 3:50 or at 4 o'clock.
Sure. I'll make this real fast. There are screening tests and there are screening tests. The currently available first trimester screening test will miss 20% of all Down syndrome pregnancies and does a terrible job with trisomy 18 and 13. That's why we're discussing this particular non-invasive test. The second trimester screen misses even more. So the whole point of the process here is to provide a better and safer test to the families and pregnant patients. Screening is not equal across the board. And newborn screening, by the way, has nothing to do with chromosome issues. It's only for metabolic diseases and single gene abnormalities. Thanks.
Thank you for clarifying that, Dr. Slotnick.
Thank you. And I'm looking around. I know that was kind of unusual. It sounds like we had just some confusion on the bill presentation, but is there anyone that has any questions for Ms. Lynch or Dr. Slotnick regarding those last couple of slides that were presented? Okay, seeing none. Assemblyman Ohrenlicker, go ahead.
All right. Thank you, Madam Chair. I just want to follow up on something, Dr. Slotnick, you just said, which was that the test that we're not covering is more sensitive, more likely to pick up abnormalities than the test we are using? And does that mean we can substitute the test we aren't using for the test we are using and then address some of the fiscal concerns?
That's the national approach right now, that we should use non-invasive DNA test for all pregnancies, for all women, as a replacement for the currently available first trimester screening, second trimester screening, which is less sensitive and less specific.
Thank you.
It looks like we have one other question from Assemblywoman Summers Armstrong.
Thank you, Chair Nguyen, and thank you, Dr. Slotnick, for that clarity. Could we ask the HHS department to give us some numbers? If this more sensitive test was used, I believe it's in the second trimester, and we didn't use the other less effective tests, how much money would we save based on the last, say, 2 years of administering tests? And if that number is equal to the difference between 40 years old testing and 35, what would that look like? I'm really curious about that.
Thank you. We will get back to you on that.
Thank you. And I don't see any further questions. And just to follow up with broadcast services, I know we had asked about neutral testimony on the phone lines. Is there anyone that is available or ready to testify in neutral?
Let me see if we had anyone join, Chair. To testify in neutral on AB 198, please press *9 now to take your place in the queue. To testify in neutral on AB 198, please press *9 now to take your place in the queue. Chair, at this time, the line is open and working. There are no callers to testify in neutral on Assembly Bill 198. Thank you.
No, thank you, broadcast services, and thank you for everything you've done. I know you've been fantastic over these 3 Braille presentations today. And everyone on the committee, thank you for your patience as well. I'm going to turn this back over to Assemblywoman Krasner for hopefully what is very brief closing remarks on Assembly Bill 198 before I close the hearing.
Yes, I'll be very brief, Chair Nguyen. I hand delivered this exhibit to each of your offices. It does show the prenatal screening tests that are currently available to Medicaid recipients here in Nevada. I'd like to thank Dr. Slotnick for his excellent presentation, and I would really appreciate your support of AB 198. Thank you.
Thank you. And with that, I will close the hearing on Assembly Bill 198. Additionally, let's see, we will be, before I close the meeting, we'll begin public comment. Again, as a reminder, please clearly state and spell your name and limit your comments to 2 minutes. Staff will be timing each speaker during public comment to make sure everyone is given a fair opportunity to speak. Broadcast services, do we have anyone on the line for public comment?
To give public comment, please press *9 now to take your place in the queue. Once again, if you would like to give public comment, please press *9 now to take your place in the queue. Chair, at this time, the line is open and working. However, there are no callers in queue to give public comment.
And do we have any comment from members before I close out today's meeting? Seeing none. Our next meeting will be Monday, March 15th at 1:30 p.m. We will not have committee on Friday. Thank you for powering through today so we could avoid an unnecessary meeting on Friday. I'm not sure what our schedule is going to look like, but please keep track of your email. I know that we will probably be getting a lot more bills in the next couple of days as those are introduced on the floor and referred to our various committees. So hopefully we'll have a full schedule next week. And with that, I would close the hearing today. Have a good day, everyone.
Thank you, Madam Chair.